Now we shift on to the last phase, which from West Indies, now we go to UK, where uh, Shibman Gill has made a century in the second innings also. So he made a double century in the first innings. Now he made a century in the second innings. And we shift to the University Hospital of North Midlands, UK, where Dr. Arjun Bhugra will talk about the vaccines and the public and private precautions that you can take. Dr. Arjun, please take it away.
Hi, thanks everyone. Thank you, Dr. Ratan, for always being in touch and inviting me for this talk. It's a privilege to talk with such greats of virology in India, especially Dr. Gupta, who has been my mentor while I did my fellowship in transplant virology in ILBS India. So I've seen the number of participants which has dwindled from around 200 257, and uh, we talk about prevention. Next slide, please. So please wait for the vaccines to come. That becomes more interesting. But as all the other speakers have told you, that how it's important to know about dengue, and diagnosis of dengue is very important when it comes to the presentation of the symptoms. So now, after going through all these things and realizing that we might not be very soon coming up with some antiviral to control this virus, we have started concentrating since ages more on the prevention, because prevention is always better than cure. Next slide, please. Next slide. Yeah, so we talk about public health policies. Public health policies for dengue, especially, which is one of the neglected tropical disease, come from two main bodies. The one for global and different regions is World Health Organizations, and the one which we have in India is Government of India under National Vector-Borne Disease Control Program. It has given guidelines for integrated vector management for control of dengue and dengue hemorrhagic fever. So these basically concentrate towards your environment, which you can modify. Modifications can be improvement in water supply, any long-lasting modification, which basically leads to transformation in the vector habitats and then reducing the number of vectors and hence preventing spread of dengue. It can be environmental manipulation, such as temporary changes to vector habitats, which we see in summers in India. And it can involve essential and non-essential containers, which basically become natural breeding sites as the season for as the monsoon season comes in different parts of the country. It can also be changes in human habitations, and efforts are made to reduce man virus contact by this. We can do mosquito proofing. We can use screens in our doors and windows to make sure that mosquitoes do not enter and thus prevent the contact with them. Then we have another thing, which is personal protection. So if we have protected our environment, now it's time to do some personal protection, which can be done by protective clothing, repellents, which are common, and uh, we can use household insecticide products, namely mosquito coils, pyrethrum spray sprays, and aerosols. All these are in the guidelines which are provided by the government of India. They also talk about biological control, in which we have larvivorous fishes, which are recommended to control Aedes aegypti in large water bodies. And they also recommend endotoxin producing bacteria such as Bacillus thuringiensis serotype H14, which has been found effective for as an effective control for the mosquito population. Then there are other methods of control, such as a chemical, in which we have used larvicide, we have used adulticide chemical sprays, but they are not very famous nowadays, because mosquitoes are basically becoming resistant to them. And so the main as a virologist, I think the main and a public health student, I think the main area which can bring a change in decreasing the man to virus contact is decrease in the number of population of the mosquito, and that can be very well done if we control our environment and personal setting. Next slide, please. So Government of India also participates in by bringing out legislative measures such as civic bylaws, which say that punishment is imparted if breeding site is detected due to someone's mistake. This has been strictly enforced by Mumbai and Navi Mumbai, Chandigarh, and Delhi municipal corporations, which are hubs for these kinds of problems. Then there can be Building Construction Regulation Act, which should make appropriate guidelines of how buildings to be constructed, because the urbanization of Indian metros and the second tier cities have led to more breeding sites, which have led to increase in the population of the mosquito. Then government has also come up with Environmental Health Act, in which there are suitable bylaws, and they've been made to make sure that there's proper disposal of storage of junk, discarded tins, old tires, and old debris. And there are also health impact assessment which are recommended by these guidelines. When we come to health education, it is done at three levels. It is at household level, as I just explained. Then it is done at community level, in which the people of the community are brought together and they're made to understand why it is important to have cleaning and covering of water storage containers. Why is it important to keep the surroundings clean, improve basic sanitization? Then they're also told about these kinds of personal protection, which I just described, and they're also told about how they can make sure that man to mosquito contact is provided. And the institutional level, which is the most advanced, but might not reach everyone in one go, is at hospital, schools, or college levels, in which the upcoming doctors, upcoming healthcare workers, and everyone else is explained how the decrease in the number of the population of this mosquito can actually lead to prevention of this disease, because it's a vector-borne disease, and that's, if the vector is eliminated, we will be able to control it. Is what we go with when we talk about public health policies. Next slide, please. So, as I said, what you see here is different kinds of personal protection and environmental protections, which we discussed, have been explained very nicely in illustrative figures. So these figures are actually used by Government of India under national schemes, so that people just see these posters and understand what they are supposed to do, especially the ones who are not able to read and write. So it helps out everyone, and that's how they are making it accessible to the masses of population. Next slide, please. So this slide basically tells you different future of dengue surveillance and control, which we can go ahead with, and which we are actually going ahead with. We have discussed point of care assays, we have discussed better distribution of tests, then case reporting as has been taken by some of the infectious disease specialists, and then there are environmental things which can be done, like next generation mosquito traps, entomological surveillance, which can be done by the government agencies. And then we also have molecular epidemiology, as has been very well explained by the former speakers in this presentation. Next slide, please. So now we move on to a very important prevention strategy. Once we have known that we might not have a lot of antivirals developing for this disease, so we basically try to move on to different kinds of vaccine. We try to develop different kind of vaccines, and we try to see how they would be helpful to us. So there are different vaccine candidates which are available for dengue, and a few are on your screen. I would say most of them are on your screen, but we have not been able to make very good advances in all kinds of strategies or all types of vaccines which have been developed for dengue. So let's start with live attenuated vaccine. So live attenuated vaccines, basically, what does this mean? So what we'll do is, in this and the next slide, we learn how these vaccines act and why these are important. And then we dive into live attenuated vaccines, the ones which have been approved for use in the endemic areas for dengue. So live attenuated vaccines basically are made up of weakened forms of living pathogens, which have been weakened to make sure that they are less harmful or are non-pathogenic. As I say, they are live attenuated. So attenuation basically means weakening them. So this kind of vaccine is one of the best when it comes to high endemic areas because it delivers different range of protective antigens against which an immune response can be generated, and that can mimic a natural infection actually. So various live dengue vaccines have been developed using recombinant DNA technology. Uh, some of them will be discussed today. Three of them will be discussed today. So to name them, it's CYD-PDV. There's recombinant DENV4 mutant with 30 nucleotide deletion, which is basically the Takeda vaccine. And then we have tetravalent virus dengue vaccine, Denvax, which we will be discussing in the upcoming slides. So whoever is controlling the slides, I'll just like you to press it once, press the keyboard once or mouse, whatever you're using, so that a circle comes on the vaccine which we are discussing. Can you press it, please? Now press it again. Yeah. So now we come to, no, go to inactivated vaccines, please. Thank you. So now we come to inactivated vaccines. What these vaccines are basically, in this inactivated vaccine, material derived from the virus has been inactivated using different physical agents that allows the immune system to recognize the antigen and produce an immune response without virus causing the disease in the human being. So that's the basic idea behind inactivated vaccines. To name a few, we have TDEV PIV vaccine, we have DENV2 vaccine S16803. So these are the two inactivated vaccines, which we'll see in the next slide are in which phase. Please move on to the next one. Thank you. So when we talk about virus-like particle vaccines, these are basically vaccines which mimic the structure of virus without containing any genetic material. So as we know that genetic science and technology is advancing, we are coming up with different delivery methods. The whole purpose of this vaccination is to deliver an antigen in the body of the human and create an immune response, which will basically lead to uh, immunity against dengue virus. So that's the whole funda behind it. So it's basically virus-like particle does not have any genetic material. These particles are recognized by antigen. So because they resemble or mimic virus in some ways, they are basically identified by the antigen presenting cells, which basically will do their uptake and subsequently present them to the lymphocytes, hence leading to generation of an immune response. So please, next one, please. So when we talk about subunit vaccines, we have, again, another method of introducing an antigen to develop immune response. So these are constructed using defined protein antigens, particularly envelope proteins, as Dr. Ekta had described different proteins in, sorry. Okay, so as Dr. Ekta had described different proteins in her presentation very clearly and nicely. So that one envelope protein is used for producing subunit vaccine. It is produced in heterologous expression systems such as eukaryotic and prokaryotic cells. To name a few, we have ED3P64K as a subunit vaccines. All the vaccines which I tell you, apart from the live attenuated vaccines, are still in some phases of trials, which I'll describe in the next slide. Please move on to the next one. Thank you. So coming to viral vectors, what viral vectors are, and I'm very sure that most of you know about it because we have just gone through a pandemic and the survivors know about different viral vectors which have been used for COVID-19 as well. Almost the similar concept. So these basically employ viruses that have genetically modified replication. They have been genetically modified to make sure that there's a replication defect in them, and they cannot cause human disease. So, but they still have ability to enhance immunostimulatory properties once they've been introduced with the dengue antigen. The viral vectors which have been used for dengue are adenoviruses and alpha viruses, vaccinia viruses. These all have been tried out, and they act as a delivery system, introducing the genetic material of dengue virus in the host cell. So a recombinant replication defective adenovirus vector expressing dengue envelope proteins has shown a very good robust antibody responses in animal models. But still, human trials are awaited, and we are going through these. Maybe in another 5 years or 6 years, when we have this presentation again, we'll come up with something. Moving on to DNA-based vaccines. So this basically means that a DNA vaccine, which basically is a plasmid that encodes specific antigen from dengue virus, will be introduced through different methods in your body, can be intramuscular, and then that antigen which basically has been introduced will be presented to antigen presenting cell, and then both humoral and cellular kind of immunity can be produced against it. So these basically are different kinds of delivery system or types of vaccines which have been worked over by different scientists. Next slide, please. Thank you. So different scientists are working on them, different institutes are working on them. What you see here is live attenuated vaccines, all of which have been licensed now. And then we have DNA vaccines, which are in phase 1 clinical trials. Please go anti-clockwise. Then we have DNA vaccines, which are in phase 1 trials. We have peptide-based. Please don't move the slide.
Arjun, please, let's move on to TAC 003, because that is the one which is licensed. And because we've crossed the time that was allotted to us.
Okay. So can we go to the CYTDV, please? Next slide.
See, what we
Next
need
slide,
to
please.
understand is why the vaccine will work and
Yeah.
what is the
Next
danger
slide.
of the vaccine.
Yeah. So now, as we are coming to the live attenuated vaccines, please press it 3 times. So dengue or CYD-TDV, it's a chimeric yellow fever. So CYD-TDV basically means, please press it 3 times. So CYD-TDV, chimeric yellow fever virus DENV tetravalent dengue vaccine. This is also known as dengue, which you see on your screen. Please press the slide, that thing one more time. It was first licensed uh, dengue vaccine, which has been produced by Sanofi Pasteur and has been approved in some countries. But the thing about this vaccine is it can be used only in people who have been who have who have had exposure to dengue virus before this vaccine is given. So before giving this vaccine, we always do a serological test and confirm that if patient has IgG antibodies present, which basically means exposure. Now coming to the vaccine proper, what you see here on your screen on the left side is, it's basically a vaccine which uses yellow fever 17D vaccine strain as backbone, substituting yellow fever 17D PRM and E regions, in which we have used DENV 1, 2, 3, and 4 regions. And the backbone which is used is a yellow fever virus backbone, basically. So preclinical studies have suggested in Macau that it produces a very good response for DENV1 and 4. And phase 1 and 2 clinical trials have shown data on safety and immunogenicity of vaccine formulations and immunization schedule. The immunization schedule basically is that you've got to give 3 doses of this vaccine, and all of those should be 6 months apart. What we have seen is that immunization, please press it once more. After licensing, what we have seen is overall vaccine efficacy in children between 2 to 17 years is 60%, but the protection against serotype 3 and serotype 4 is 75 and 77%, respectively. But against serotype 1 and 2, it has just been 40%. So that's one disadvantage of this vaccine, though this is one of the best vaccinations known right now and has been used. The immunization also has a 72.7% viability against hospitalization and an efficacy rate of 79% when it comes to severe dengue in all the age groups. It has been recommended that this vaccine has to be used in people who are above 9 years of age, 9 years to 45. And it also has been recommended should not be used in individuals who are infection naive, because it has been noticed in the trials that if this vaccine is used in infection naive individuals, they can later on develop severe dengue due to all the immunopathogenesis which have been described by all the speakers before me. So basically, it's a complex virus with complex immune regulation and dysregulation pathways, and that's the reason why it cannot be used in those individuals. Please, next slide, please. When we talk about TAC3, TAC003, which is Qdenga, which has been produced by Takeda Pharmaceuticals. This is also live attenuated tetravalent dengue vaccines, which has chimeric viruses which encode for dengue virus 2, vaccine strain 16681, passaged in primary dog kidney cells, and tetravalent dengue vaccine 1 to 4. So the thing about this vaccine is it has been approved in individuals 6 years to 45 years of age and has been approved in Indonesia with authorization in European Union for people aged 4 years or older, regardless of previous dengue infection. So that's one good thing about it. TAC3 has also been given a priority review by US Food and Drug Administration for prevention of dengue by all four serotypes. So in phase 1 trials, we have seen that it was sufficient, one vaccine dose was sufficient to generate the necessary amount of neutralizing antibody to inhibit DENV2, and no serious adverse events recorded. Most of recipients only experienced erythema and pain at the injection site, which is a very, very minor side effect as compared to the kind of disease which dengue virus basically gives you. In phase 2 trials, no serious adverse events have been recorded, and most of the recipients have just those two side effects as described, and 2 dose schedules were more effective than 1 dose schedule in increasing the seropositivity rates in dengue naive infection, infection naive individuals as well. Overall sensitivity in phase 3 trials has been 73.3%, and in second year after vaccination, the efficacy dropped to 56%, and it was suggested that this could be due to change in predominant dengue serotypes, as we have seen in the previous parts of presentation, how serotypes keep on changing and affecting. After licensing, it has been well tolerated and not linked to any serious side effects. Its efficacy against virological confirmed dengue was highest against DENV2, which was 98%, and lowest against DENV3, which was around 63%, which is better than the previous vaccine. After 4 to 5 years of post-vaccination, the cumulative vaccine efficacy was around 59%, which is good enough as compared to the previous vaccine, the CYT-PDV, which we discussed. Please move on to the next slide. Now coming to the last candidate, which has recently been licensed in US, and so this vaccine basically has been developed by National Institute of Allergy and Infectious Disease and is currently in 3B clinical trial phase against dengue. So it has 3 genetically attenuated viruses and 1 chimeric virus. This vaccine incorporates 30 genetic deletions in the 3 untranslated region, making further changes to non-primary proteins and producing recombinant DENV1, 3, and 4. So the Buchanan Institute, so what they did was they did a study in Brazil because it's one of the countries which has a very high rate of dengue. It's around 107 cases per 100,000 inhabitants. So the Buchanan Institute accumulated data from 16 centers in Brazil and found out that a single dose of tetravalent vaccine showed 80% protection among participants with no evidence of previous dengue exposure and 89% protection in those with history of exposure. So which is even better than the previous 2 vaccines which we have discussed. So this is the current picture of 3 licensed vaccines. Please move on to the next slide. And this is a very comprehensive table which basically says that dengue licensed, phase 3 completed, also licensed now, to be given in people who are 9 to 45 years of age. The age range here basically is 2 to 16, and in here it's basically quite better as compared to the other 2 vaccines. We have talked about the efficacy of these vaccines, but the good thing about TV003 is that only 1 dose is to be given, and Qdenga uses 2 doses, and Dengvaxia, the older one, has still 3 dose schedule. Please move on to the next slide. So in Indian scenario, we have Tetravax DV. Thank you for providing me this slide. So this vaccine contains a mixture of 4 plasmids, with each one encoding PRM and E genes of one DENV serotype. And Merck and Sharpe is developing recombinant protein vaccine in India. This vaccine, the vaccine companies, Serum Institute of India Biological E, have been granted non-exclusive licenses for developing these, and they have initiated phase 1 and 2 clinical trials with enrollment of 200 healthy volunteers in age group ranging between 2 to 60 years. Then when we talk about DSV4, it's a tetravalent vaccine candidate that uses virus-like particles platform, the ones which I described before, to induce immunity against all 4 dengue serotypes. So that's the basically type of delivery in this vaccine. And it has been developed indigenously by International Center for Genetic Engineering and Biotechnology, New Delhi, ICGEB, and Sun Pharma, which is in Mumbai, extensively evaluated in animal models, but still awaiting human trials. Next slide, please. So, what is the challenge when it comes to developing a vaccine? Next slide, please. So the challenge when it comes to developing a vaccine is, despite having 3 licensed vaccines, we have not been able to show long-lasting immune response, as we have seen in the previous slides, that either the immune response comes to 45% or 56%, and that's in 1 year of giving the vaccine. The best response which we had was 59%, and that was after a couple of years, which is very low when it comes to endemic areas and infection-naive individuals. The balanced immune protection has not been reached yet. There are certain vaccines which go with DENV 1 and 2, the ones which go with DENV 3 and 4, but not all serotypes are affected the same way. So what would be an ideal vaccine? Ideal vaccine of dengue is supposed to be a multi-type immune response producing vaccine with a long-term response. So that's what we are trying to achieve with different kinds of delivery methods and different kinds of vaccines which we are developing. Next slide, please. Next slide, please. Okay, so I think I'll just give you the idea of what I was about to say. There are different challenges when it comes to developing a dengue vaccine. So first is antibody-dependent enhancement of disease, as has been explained in few of the infection-naive individuals, leads to severe kind of dengue infection when it comes to giving a vaccine and then giving a vaccine to an individual which is infection naive. But we have seen with different vaccines that this can be prevented, and it is still being studied. The other challenge to develop a dengue vaccine is cross-reactivity with other flaviviruses, as very nicely described that it belongs to Flaviviridae and it has so many other that family basically has so many other individual viruses which have cross reactions in their antigen. Multiple DENV serotypes have limited antibody response. That's the third challenge. The fourth one, which we think is the epidemiology and transmission of this virus, is very, very varied when it comes to different regions of the world. It's high somewhere, it's low somewhere, it's different season somewhere, different season here and there. So
all right,
totally